Please somebody check and tell me if it's live or not. I think I'm live.
Okay, I'll go check.
Please somebody check and tell me if it's live or not. Okay. So welcome to a new edition of Sense of Medicine Case Control. Today we are going to talk about vascular malformation of the brain. And we are going to, obviously we are not going to cover every possible aspect of it, but this is an interesting case of a patient who is actually a young 20-year-old Hispanic American female who presents to the ER with seizure. Now, I'm going to just ask, I'm not sure if anybody has going to join us on the Zoom, and I'm going to send the Zoom link to a few people. So other people can join me on Zoom and help me to moderate this. So I send it to Amanda, Misha, Dr. Coach, and Neil. I'm not sure if Neil is with us today or not. And Alyssa as well. So somebody please join and help me to moderate and answer or let me know if somebody is asking for a comment. Oh, Neil is here. So Neil, I'm sending you the link so you can join in and help me to moderate. So young patient comes to the ER with mostly seizure. And the first question is going to be asked is what kind of seizure? It's a seizure with Jacksonian march, which get generalized. I'm not sure if you're familiar what that means. Means that the seizures start in one of the extremities and then goes proximally, and then when it all of a sudden start going across and other side as well start seizing, cramping, then at this point actually patient loses consciousness. Neil is joining us and Amanda is joining us. I'm going to ask Neil a question. Neil, are you with us?
Hi, yes, I am.
Neil, a young patient coming to the ER with seizure. Always, what information would you like to know in this patient with a seizure, and what is your workup?
If the patient is coming in for a seizure, first thing I want to do is get a history as well.
Yes. No. First, you wanna see the patient and see if the patient is stable. You know, in this medicine, you have something called ABC. Are you familiar with that?
Yes. Airway, breathing, circulation. There's
Exactly.
D&E for any disabilities and any exposure. So you want to do a full head-to-toe assessment. See if there's, for example, anything on their clothes that could be causing this, or see if they have any wounds or things of that nature.
So you ask me the question and I will give you the clinical information. And there is absolutely no wrong answer, Neil. I want to say that if you guys knew everything, there was no reason for you guys to be on this meeting. So, yeah, and if anybody else want to join and participate, I welcome that. So Neil, do not hesitate, to just answer and we will move on. So ask me a question and so what do you want to know about this young Hispanic female?
Young Hispanic female. How old is she?
20.
20. Is there any family with her? Anyone that she knows? Okay, I would like to ask the family, has this ever happened before?
No, first time.
First time? Okay. Do they know what was happening prior to the onset of the seizure? Is anyone there?
They just came to the kitchen and she was seizing. she was cramping. So you want to know what kind of seizure, you know, you want to expect. Now, this is from the description they give you, you notice that this is a generalized grand mal seizure.
Grand mal, yes.
You want to describe what a generalized seizure or grand mal seizure is?
Grand mal seizure is when there, in comparison to the others, there are no focal deficits. It's more of a, is that myoclonic?
Well, it is practically patient loses consciousness, and it's actually moving all four extremities.
Like a tonic-clonic seizure?
Yes, tonic. That is the grand mal seizure is a tonic-clonic seizure of all four extremities.
You would have, so you can have the tonic phase and the clonic phase. The tonic phase is when you have the muscle contractions, and the clonic phase is when you have the muscle twitching occurring.
Okay, I'm going to give you one better. While you are there talking to family, she start seizing on the left side of the body, and then within 30 seconds, the right side starts seizing as well, and then she become unconscious. Is it something unusual that when one side is seizing, they have consciousness, but when both sides are myoclonic motion, they lose consciousness? Is that unusual?
I think this, I think it is different, because I know with clonic seizures, they're bilateral.
Well, you know, first of all, that people can have a seizure on one side of the brain without losing consciousness. When the seizure activity passes both sides, that is when people lose consciousness. As a matter of fact, there is a barbiturate test that I did few times, and you have to be very prepared. You put practically contrast and barbiturate in one of the carotid arteries, and you are observing once. If you put it, you know, most of people have one carotid more dominant than the other, meaning that one carotid send the blood to the other side and one side doesn't. If you do it for a non-dominant carotid, meaning all the contrast and the barbiturate state on one side of the brain, they still talk to you. But if you do it on the dominant side, on the side that send the blood from that side to the other side, as soon as barbiturate passes through the midline, goes to the other side, they lose consciousness. It's important because I do that to see the dominance of the brain. So I did that test to practically, you know, patient is left, you know, let's go a little back, it's getting more interesting. What percentage of the people are right-handed, Neil? What do you think?
I believe it's 90%. Well, I know with the United States, only 10% of the population is left-handed.
Well, it's actually in the United States about 80% of the people are right-handed and left brain dominant. From the left, 20% or about that. 20%. Actually, many are ambidexter, but 10% are left hemispheric dominant. When they are, I'm sorry, 10% are left-handed. From those that are left-handed, actually, what do you think, what percentage are left hemispheric dominant and right hemispheric dominant?
Would that be, honestly, I'm not sure.
Half. People who are, that's amazing. People who are left-handed, still half of them are right hemispheric, half of them are right hemispheric dominant, but still half of them are left hemispheric dominant. That is amazing, and you cannot just assume somebody is right. So in most of the people, left brain is dominant. It doesn't matter your right-handedness, or if you are right-handed or left-handed, because half of the people who are left-handed, still left brain is dominant. The other half are either left hemisphere is dominant, or they are ambi-hemispheric cooperation. So imagine somebody has a tumor on the somebody who's left-handed has a tumor on the right side, you want to know on what side is the speech of the brain. Again, vast majority of the people, our speech is on what side, Neil?
The speech is on the left side.
For vast majority of the people. Now, this person, imagine you have a patient who has a right-sided tumor, and this patient is left-handed. Then you want to know if this patient is, if that tumor is on the area what is important for the speech or not. To understand and be sure completely, we put.
You don't want to assume he's a part of the majority.
Because if you take a tumor out of somebody and you are not extremely careful on the dominant side, they lose their speech completely, and that is devastating. Losing speech is a devastating disability. So to be sure, you put two catheters, one on the right side of the brain, one on the left side of the brain, and you very gently practice with barbiturate or propofol. You put one side of the brain to sleep and see if they still can sleep or not. That exactly happened to this patient I'm going to show. So, but what you see then is, first of all, if you do the side of the brain that is not related to the speech, they don't lose the speech, but on the other side, they do lose the speech. So then you know which side of the brain is controlling our speech. But as we were talking about, in vast majority of the people, one side of the one carotid sent blood as well to the other side. So while you are testing the patient, you are putting barbiturate and contrast, you see when your contrast and the barbiturate, if it's crossing or not. But as soon as it crosses the midline, almost everybody loses consciousness. So this is a very delicate test that proves to you on what side the speech is practically localized. But if you do vascular studies, if you do vascular surgeries as well, we can estimate on what side, what carotid can give blood to the other side and how much. Because imagine somebody has a problem in one of the carotid, a tumor or something, you have to take that tumor. Is he going to tolerate that or not? This is a good test to find out if practically that side of the brain is getting a lot of blood from the other carotid, from the vertebrals, and so on and so forth. So, so in this patient that I'm describing to you, this patient is left-handed. And that means that there's a good chance that the right side of the brain of this patient, this young woman, controlling the speech. And what you notice is that the seizure start on the left side, meaning that is a right hemispheric event, but then eventually it crosses the midline, and at that point, a Jacksonian seizure or Jacksonian march passes the midline, and patient goes into a grand mal tonic-clonic seizure. So first of all, patient is having a seizure right in the ER. What do you do, Neil? ABC.
So ABC, I want to check the airway. I want to check their breathing and their circulation, any disabilities or any exposures in the environment.
Okay, none of that. But first of all, you want to put them in a safe position, meaning like a lateral decubitus and so on. Make sure they're getting enough air. But the next step after that, you have to break the seizure, right? You cannot let the seizure just go unchecked. And you cannot intubate while somebody is seizing. Can you intubate somebody who's seizing?
No, you can't. That'd be extremely dangerous.
Yeah, no, well, you can. You have extraordinary skills. If you can intubate somebody who is jumping off the bed up and down, that is would be very, very extraordinary steps. Now, what do you do? So first of all, if the seizure is very severe, you paralyze them and then intubate them, emergency intubation. But if the seizure is not very severe and they are able to breathe, you can give them some medication that almost certain break the seizure. What medication comes in your mind, Neil?
benzodiazepines.
Benzos are very good medication for that. We used to give barbiturate. Don't do that
Barbiturates
anymore.
are a lot more potent.
Well, the half-life is much longer. That's why we don't give it.
I know with the mechanism of them, the barbiturates allow the ion channel to stay open longer, but the benzos allow the frequency to pulsate faster in a way that, the half-life. So it's less toxic on the patient.
Well, you can reverse them easier and you can just
Mhm.
control it more. In an emergency situation, you always want to give short-acting medication. So you give short-acting medication. Amanda, if somebody else wants to join us, please invite them and send them the link. Now, so this is not a very severe patient airway is okay, and you give some Ativan. We talked about that benzo. Some people give Valium. I like Ativan, or even better, Versed. Have you heard of Versed?
I have heard of Versed, but I'm
Yeah.
forgetting what the medical name of the drug is.
Well, Versed is good medication. So
Mhm.
you don't need to know any other name for that. Versed is a very common. Ativan is a very good medication as well, and some people even take it as a sleeping pill. But
Mhm.
Versed is a very potent, short half-life, and so you give 2 milligrams of Versed, and it doesn't really do much. But you repeat it 2 more times, and then seizure stops. And
When would
patients,
the drug Keppra, the anticonvulsant, come into play here? Is that to maintain them?
does not to breaking the acute. It does come to play to prevent the more seizure in the 4 hours later and so on.
Okay.
But to break the seizure, depending on the situation, either you have to paralyze the patient and intubate, or start with sedative, heavy sedative. Propofol could work. Propofol is a good sedative, and you can even dose it, but that requires an anesthesiologist for you to use the propofol, because you have to dose it very, very carefully. If you dose it too much, they could breathing. But Versed is a safe medication. You give 2 milligrams, wait a minute or so, give another 2 milligrams, and then after third dose and 3 minutes, seizure slows down. And at this time, what happens once the patients stop seizing? They're still not conscious. It will take them about 5 to 10 minutes, and then they slowly regain consciousness, and then they become more and more lucid. Within half an hour, patient is lucid again. At that point, you give Keppra or other carbamazepine or phenytoin or other seizure medication to make sure that you reduce the chance patient going to seizure again. That is where the value of those other preventive drugs is. But in the acute phase, you can give it, but it won't work for you in that situation right away. So, patient is lucid now. You do your neuro exam. More or less, after patient regain consciousness and is lucid, your neuro exam is normal, Neil. So what is the next step? You mentioned it already.
Well, the next step, if my neuro exam is normal, I would like to think of some differentials of what could have caused this. Was it a febrile seizure? Was it, which could indicate infections?
Febrile seizures are very rare. It's a good thing in the kids. Very, very important step in the kids. But febrile seizures are extremely rare in adults. But yeah, it's possible. No, patient didn't have a fever or any kind of flu or anything like that. So, but obviously you will do a drug screening. You do BMP. You should make sure that the sodium is not very low and so on. You make sure that patient is not on some other medication. But by the fact that you saw the patient starting seizing on the left side, you're assuming a right hemispheric event. So you mentioned that. What are we going to get? What kind of study are we going to get?
Oh, a study, maybe an EEG?
Not in the ER. You will get an EEG, but not in the ER.
Yes.
So you mentioned the CT. I think it's a good idea to get a CT. And that is your CT.
Okay.
Now, let me share it. Are you able to see it?
Yes, I can.
Okay. Now, you get a CT because you know that this is a right hemispheric event. Something is in the right hemisphere causing this problem. That thing what could be in the right hemisphere that caused the seizure? What is the differential diagnosis of a mass or anything that can push on the surrounding tissue, cause a seizure? What's the differential diagnosis there?
My differential here, by looking at the difference in
Before you look at this, you know, it could something that could cause a mass, obviously could be a bleeding. When you check the patient, there is no trauma. This is a young patient. In the elderly patient, they can have a spontaneous bleeding. This is a young patient, no trauma. There's still a chance, a spontaneous bleeding there, but that chance is very low. But now that we are talking about the bleeding in a young patient, what kind of diseases cause the bleeding in a young patient, not in an old patient?
I'm going to start to think of coagulopathies. I could also think of the vasculitis.
Vasculopathies, yeah. There are lots of, now, there is a disease event that, you know.
I did think of one disease. Yes. I know autosomal dominant polycystic kidney disease.
Yeah, that is a rare disease, but yes. But there is another disease that is more often in the younger people, especially in the Asia, especially in Japan.
Oh, are you thinking of giant cell arteritis or Takayasu?
That as well, but have you heard of Moyamoya syndrome?
Actually, I have not. Maybe.
Well, that is a different topic for a different time, but there are lots of different vasculitis that can cause so in a young person, you think of vasculitis, rheumatoid disease, and those kind of problems. In the elderly, just the degenerative vasculitis and stroke, hemorrhagic stroke is the most common problem. So beside the bleeding, what else can cause the mass there? Obviously a tumor. Now, when we talk about the tumor, we have to separate people who are in their 40s, 50s, 70s and above, and children and younger people. So we know that in the people, the glioblastoma multiforme has a biphasic penetration, meaning people with in their 40s, 50s, and in the 70s and above, they have a prevalence for glioblastoma, and that's a one of the most important and common tumors there. In children, obviously, pilocytic astrocytoma in the posterior fossa in the cerebellar region, obviously medulloblastoma, but as well some other astrocytomas and oligodendroglioma are often in the younger people, meaning in their 20s, who are not children, but they are not in their 40s and 50s or 70s and above. Vascular, we obviously have to think of oligodendroglioma, but as well we have to think of other vascular, not bleeding, but vascular tumors. So just by looking at this, it is really, can you describe, Neil, what you see in the CT?
I think what I'm seeing, because of the color difference with the brain, I'm thinking this is a bleed. I think this patient is bleeding in there.
Okay, so let's start with first of all describing it. This is a CT of the head in the axial view, and we are able to see a right frontal mass. Is that correct?
Correct.
And the mass is not homogeneous. That color difference that you mentioned, Neil, very good. You noticed that. We have a name for that. What's the medical terminology for that color difference?
Hypoattenuation?
Well, we call it hyperdense. If it was MRI, we would call it hyperintense. In CT, we call it hyperdense. And you know what? There's a beautiful thing that for people who actually were involved in our physics of the CT, they know that you can actually measure the Hounsfield unit of this. If you haven't watched that, I'm going to ask Amanda to put our CT meeting up again, and you can go and read about what those Hounsfield mean and how they are calculated. Depending on the scale, if your scale is the -1,000 to +1,000, blood is 70. So you measure that. This is not entirely blood. There is obviously some blood in it, but the density of this is more like 40 and 50 and 60, is not 75 or 80. So it's not exactly blood. So now that we know, based on the CT, we know it's not blood. But what's important as well is that it is not causing any flow restriction of the CSF, meaning that it's not really what we call the temporal horns are not really huge. And now we get an MRI. Now patient is stable, we get now an MRI.
This is more clear to me.
So what do you think it is?
So now I'm thinking it is a tumor. It is a mass of some sort. And it's not homogeneous. I can see with the irregular borders as well.
What do you, there is a word that actually is a medical word there. And if you hear that word, the diagnosis is clear. The word for this, is there anything in your life, Neil or Amanda? Is there anything in your life? Just look at that area where the tumor is. Is there anything in your life that comes to your mind when you look at that? Amanda, I give you a big box of chocolate, or Neil to you. Whoever says first, what thing comes to your mind in your daily life that look like that?
Looks like the sun.
What you see? No, sun. Does sun look like that? I doubt it.
It looks like the moon,
No.
if we're talking astrology, but when I see the first one, I actually think it looks more like a skin wart.
I guess neurosurgeons are hungrier than you guys, you know?
A
Oh,
cookie?
wait, is it the fried egg appearance?
No,
No.
good one. No.
What is it?
What
Wait,
do you get when you go to movie theater?
Popcorn.
Popcorn.
Yes, popcorn. We have this name for that. We call it the popcorn appearance. You see how it looked like a popcorn? Well, a hungry neurosurgeon would see that. When you see the word popcorn appearance, and you see that literally the dark thing around that, and then this inhomogeneous appearance, that is, every neurosurgeon knows that when you see that, you think of one very specific diagnosis. And that specific diagnosis called cavernoma. What do you think what a cavernoma is, Neil?
I believe a cavernoma has to do, well, I know in the brain we have a cavernous sinus. There's a cavern hemangioma. Is this having to do with the sinuses in the brain, or am I off?
Let's first of all talk about the vascular malformation of the brain. If it's part of the artery just bulges out, what do we call it? Aneurysm. If it's a part of the artery that directly feeds to a vein, we call it arteriovenous malformation.
Yes.
If it is a lots of small capillary, they just go wild, and there's lots of accumulation, and nature gives you everything. We call that hemangioma. Now, if it is a part of the vein that is getting big and literally becoming like a mass, we call that cavernoma.
Okay.
So, and what's special about cavernoma, because there are lots of vessels that are veins, and they're in the places they shouldn't be. You are born with it, and it grows, it bleeds into that, It coagulate, the blood coagulate there, and then it just changed the thing and it start growing. As a matter of fact, you see it's dark around it. That is so-called hemosiderin, meaning that the iron of the blood, after the blood bleeds into that, the rest of the biologic material gets reorganized, but the hemosiderin, the part of the blood that has literally iron in it, residual of that give you that signal. That is like almost like an artifact, almost like a metal artifact. So, and that is what the typical appearance of the popcorn appearance comes from. So this is a vascular malformation of the veins in our brain. And because it bleeds into it, and then it opens up, then bleeds into it and opens up, it's not exactly blood because it's not fresh blood, but it is made of organized blood, old and new blood bleeding, and it grows. And because of that, it grows. And when it starts pushing on certain areas, it can cause seizure, and patient's speech is good. But why am I even concerned about this speech here? Who can tell me why something like that is always important that we check patients at speech center?
Isn't it because we're going to be worried about, I guess, one, mass effect, if this starts to continue to grow, and then two, when you want to operate, you want to know your margins, like how far are you?
Yes. You want to know if these patients, if you take that out, how careful you have to be. Obviously, you don't want to leave anything behind, but if there is even a bad tumor, I rather don't damage the speech center than try to be the hero and take all the tumor out, and then patient wakes up, lose completely their speech ability. That is devastating. Now, people, it's extremely hard to recover from that if they lose, and in this area, and there are two centers for our speech. Neil, you want to name them for me?
Broca's and Wernicke's.
So which one would I be concerned about with this tumor?
Well, since it's more anterior,
which one is front, which one is back?
So the Broca is more anterior and Wernicke is more posterior in relation to each other.
Correct. I'm not going to go to the detail, even with gyrus and so on, but this is
the lingulate gyrus.
Well, let's just we don't want to get too fancy here, because I think you have to be a neurosurgeon to know the more specific like Wernicke, if you want to know, is closer to the angular gyrus, and the Broca can be inferior the frontal to the temporal, that corner. But either way, we are concerned about that. In this patient who is left-handed, the speech is good right now. Patient has no deficit, so we don't want to give that deficit to the patient. So let's go next slide. And here, another picture, the so-called fat suppression picture that you see again is a popcorn appearance. Another picture, and here, for people to understand that, how you see that it's getting to the frontotemporal region on the bottom, if you go to the base, and that is where you get concerned about the Broca area. Neil, you still get something if you tell me what this is and how I got this picture. What is this?
To me, this looks like an ultrasound.
Can you get an ultrasound of a tumor in the brain?
I've never heard of, no. I mean, I don't know.
So what's going on? Is it ultrasound, first of all? Is it not ultrasound? If it's ultrasound cannot pass the bone. How do you get the ultrasound? If it is ultrasound, in fact, how do you get that?
That is a very good question. Is it
Should I give you a good answer, Neil?
Yeah.
The intraoperative ultrasound. So I open the skull.
Okay.
Before I open the once the skull is off, you open the skin, flap, the ear-to-ear flap, open the skin, open this, take a skull out, and then under the skull, before I open the dura, I put an ultrasound on the dura, and then localize the tumor. Do you see the tumor now? This is an ultrasound, intraoperative ultrasound of the tumor. You see it's well defined,
Yes.
right? You see the ventricle, you have to know the orientation, otherwise it means nothing to you. You have to be there, you have to know what direction you're putting it in, and to understand the anatomy. So
Are
I'm
you
not-
using the ultrasound while you are operating so that you can
Correct.
guide your?
While
Okay.
I'm in the OR operating on this tumor, I'm getting an ultrasound of this tumor. It's very common, especially before the age we had neuronavigation. The ultrasound is how we localize the tumor after we open the skull. So see, there is a neuronavigation these days that, the machine tells you exactly what's the shortest path to the tumor. We didn't have it, or it wasn't always available, and it wasn't always good. So we did measurement of X-rays and so on, and based on those X-rays and those measurements of the CT and X-rays and MRI, we have a good idea where to open the skull to get to the tumor. But then when we open the skull, before we open the dura, I used to get an ultrasound to identify. And here you see I'm about 1.5 centimeter under my skin, under my dura is the tumor. So I'm safe. I can access the entire tumor with this flap, with this bone flap, with this craniotomy, so I can move forward. And here's the tumor. Now tell me it does not look like a popcorn. Amanda, does it look like a popcorn?
If I'm being honest, no, it doesn't.
You guys have an interesting taste if you think it looks like popcorn.
Yeah, I think popcorn is usually like, I picture it as a different shape, but I can see it.
Yeah, well, popcorn comes in all shapes. I bet if we go to a movie theater and get a bucket of popcorn, 10% of the popcorn that look exactly like this. They're white, but
So 10%, so like as many left-handed people.
no, yeah. So I'm not going to go, but this is this so-called the Sylvian fissure here, and that is Broca is right here. And deeper, it can actually push on the fibers of the Broca. That is why it can give people, or we have to be careful. Now, once we did those tests that we just talked about with barbiturate, we noticed that the speech center of this patient is not on this side. So this is a safe kind of surgery for this patient. You see the arachnoid, you see I open one of the fissure and work on the bottom of the fissure, identify the cavernoma. Cavernoma behave like a tumor and you resect it like a tumor. It is important because some vascular malformation, they don't behave like a tumor. They behave like a vascular thing. You touch them, they start bleeding. And another time we will talk about that as well. And this is post-operative image. The tumor is gone. The mass effect is gone, but you notice the horn, the ventricular space is much more developed now because there's no more mass to push on it. So, and all of a sudden, what is that? This is a post-operative, almost 6 months after the surgery. There is another one in the back, developed this time on the left side, in the left parietal region, patient developed another one. So this patient has a chromosomal abnormality. Again, we are not going to go to the bottom of it, which they can have multiple cavernomas, okay? So
Did you say that it was caused by a chromosomal abnormality?
abnormalities, yes.
So what would be your indefinite treatment, I guess, to prevent these sort of malformations?
This was not causing any mass effect, wasn't doing anything. I sent this one for what we call stereotactic radiosurgery or cyber knife or gamma knife. Do you know what that is? The different beam of radiation come from different direction. Individually, they are not much, but when they focus together, you can literally punch a hole in the brain. And practically, and that we did that, and that area becomes like a small little scar, but then it doesn't grow and bleed anymore. Some people say it doesn't work that good for cavernoma. Some people say it does. I think the jury is not completely determinate of that, but it's more likely that it helps than it doesn't. Do you know about radiotaxy, stereotactic radiosurgery, Neil, and CyberKnife, Gamma Knife? Do you know anything about that?
Honestly, I don't know too much, but I have
Good.
heard of that.
Then
Yeah.
let's talk about it in different time, exactly only about that. So,
Yeah, I would love to learn more about that.
So, any question? Anybody? Any comment? We talked about the ER. We talked about the seizure. We talked about the ABC. We talked about the breaking of the seizure. We talked about the differential diagnosis of a hemispheric mass. We talked about some of the vascular abnormalities, but mostly we talked about the cavernoma, how they behave, how they look like, and how they are treated. So we covered a lot, but we will make sure that the record is available later on as well. Amanda, correct? And Neil, any question?
No, I just want to thank you for bringing up cavernomas to me, because now this is like my first exposure to it, I can go read up on it. So now I'm more familiar with it.
Exactly. Well, it is 4:43. We spent a lot of time today. So, but it was a good meeting. So if you have question, you can, Amanda, maybe open the comment section for this one, so they can go and ask question, then we can answer. And then
The comments are open right now. I'll leave them
Yeah.
open for a little bit.
Okay. Well, yeah, keep it open as well once you upload it to the podcast series. So thank you very much. If we are not going to have another case conference before the holidays, so Merry Christmas, Happy Holidays to everybody, and we will see you next year in another series of Essence of Medicine clinical case series. Thank you.
And watch our podcast this Thursday about the history of Christmas.
Yes, definitely.
Thank
Okay.
you guys so much. Learned a lot like usual.
Thank you.
Thanks,
Bye-bye.
guys.